have volunteer services that do assist the needy or the poor that don't have the income to pay for these services. But what we want to do is to see how we can bring people together to see if this model will work in the United States under a volunteer program. And I'm very impressed. I am here to learn and to observe and to take this back to the United States to incorporate it, if possible, into models there. So yes.
Kindly also let us know about your company.
The company that I'm currently with is Heart Test Laboratories. We're a cardiology company in the United States. We've worked with Dr. Parthos and Gupta. We are here as a screening technology for cardiovascular disease, and we're here to see if maybe we can be of help here in the camp and throughout camps in other parts of India.
Still, this non-invasive angiography is not popular in India.
That's correct.
Do you think that is as good as the invasive angiography?
As a screening product, yes, because you have the masses. So we have to identify the people that have the disease. Once we can identify those people, and once we can bring them, if they have the disease, then we can quantify it and take them onto the hospital. But the need right now is identification of the disease. So many people have heart disease and there's no symptoms. So the problem is, you may look good, you feel good, but you are sick. So if we can identify you and quantify you, then we can take you onto the hospital. So as a screening device, it is. It's the right thing to do. And it's getting better and better every year with new technology. And that's what we're doing.
First step is taking like lipid profile and all that.
Absolutely. That's the first step.
Thank you.
And you have to remember, it's only a screening to identify those non-symptomatic patients. We're not interested in the patients that have symptoms because they're going on to the hospital. What about the men and the women who have no symptoms? That's who we want to find.
Angiography has been used as a gold standard, so it's a standard for finding out if you have blockages in the arteries. But now we are changing slowly from invasive techniques towards non-invasive techniques. First we try to screen with techniques like ultrasound, and there are also non-invasive techniques like CT angiography, जिसमें without requiring any invasive catheters, you can look into the arteries and the blockages, and then you can select only very few people where actually you are going to do a procedure, and only those patients can be utilized for the invasive purposes. Non-invasive techniques are therefore help us to reduce all the radiations and also the risk of invasive approaches. So screening techniques and non-invasive techniques
do have a clear edge over the invasive ones.
I'm sorry, what?
They do have a clear edge over the invasive ones for the primary.
There is not. It's not a question of edge. It's not a tug of war. It's basically we are trying to reduce the number of people who will require an invasive approach by doing non-invasively. And this can be done at the bedside. It can be done at home. It can be done at hospital setting. You don't the patient. It can be taken to the community. You can screen people. And so basically today's camp that is the purpose. We're trying to screen and find out people who need more testing. But if you can reduce the number of patients who need to go to a bigger center, then you reduce the cost of a bigger testing and you help the patient because you're doing it free and in the community. So it's much more cost efficient for the community services.
This is my next question also. In USA, every medical facility is paid, unlike your neighbor country Canada, where there's a welfare scheme and health services are free. And in India, we have free camps like this. Do you have such camps in USA also, where people who cannot afford?
There are sometimes on occasions camps organized, but it's usually most of the patients are referred to a primary physician, and then the primary physician makes a determination whether you need a cardiology service, or there is a hierarchical way of referral processing. It's a much more organized way of doing all the investigative work. But then again, the questions have now started to come whether it is sustainable with this kind of a paradigm in which you're going on investigative approach only and not utilizing screening techniques efficiently, not using the medical bedside skills to understand who needs better. You cannot be just technique oriented. and I think we are going to see a lot of change in the near future where you will use intelligent techniques at the bedside along with the patient to diagnose if there is a need for a bigger test. So you're going to have much more emphasis placed on screening people properly, because that reduces the cost of healthcare.
That's